Welcome to Menopause the Positive Way, the podcast that inclusively supports Women Plus moving through their menopause journey with greater ease, control, and an empowered mindset. You can subscribe to this series wherever you get your podcasts. Brought to you by Positive Health, making life easier and helping you make a change for the better. Hello, and welcome to Menopause the Positive Way. My name is Courtney Pesic, and today I'm your host. Today we're joined by Dr. Lisa Miller, a certified menopause practitioner with a background spanning clinical pharmacy, mental health counseling, and women's health education. With nearly 30 years of experience supporting women through midlife transitions, Dr. Miller brings an integrative perspective to menopause care, helping women better understand the connection between hormones, brain health, emotional well-being, and overall quality of life. Her work focuses on helping women feel informed, supported, empowered during a stage of life that is often misunderstood and overlooked. So welcome, Dr. Miller. We are very excited to have you back.
Thank you. It's really exciting to be here.
Yeah. We had you back on episode 3, and I know we're many episodes in, so it's great to have a returning person.
Thank you.
Yes. So menopause conversations are finally becoming a little bit more mainstream, but in, mental health and menopause still really feels incredibly under-discussed. One of the things that I want to talk about and highlight is, as we talk about fragmented care, which fragmented care is, going to see maybe multiple doctors, right? And we're all not just connecting the dots. So how does fragmented care really impact women's mental health during menopause, and how can we integrate that support?
That's an excellent question. I mean, fragmented care is just unfortunately part of our healthcare system in the United States, but it's even more difficult for women to navigate during the menopause transition. And then even more difficult on top of that are women who have mental health conditions that maybe are misdiagnosed previously or become worse during the menopause transition. So often a woman may go to various doctors who may not recognize one or the other. So a psychiatrist may not pick up on some of the menopause related changes, and a primary care physician or an OBGYN may just make the assumption that symptoms that a woman is experiencing may be due to just menopause due to the age of the patient. So it is very, very challenging across the board for menopause in general for women, but also for mental health. It's, I think, an added layer of difficulty.
Yeah, I mean, as I talked to my friends and what I went through, it felt like I was tapping on one thing, but I was advocating for myself. And then I figured I was tapping on another thing, which was advocating for myself, or tapping on, but none of them were talking. And that brings up the feeling of feeling very unseen, right? Like even though I thought I was doing, I didn't know how to connect those conversations or connect the care, and we see it symptom by symptom. How do we navigate something like this?
Well, I mean, it's challenging. I think understanding and separating out what's going on is very, very difficult. And like you said, you can often feel very unheard. And then also on top of that, there's just a lot of misconceptions about, what's going on. So I think that it's just challenging in general. So I feel like the first thing that you need to do is to try to find a healthcare provider that understands both. So I think that can be a challenge. But being very careful to ask very detailed questions and get second or third opinions if necessary. I mean, just to share my own personal experience, if I may, I experienced sort of what you just described as in my mid-40s. I thought I was developing early onset dementia. I really did. I had a lot of issues with my memory and forgetting people's names and just all of those things. And I went to my primary care physician, and and I'm a pharmacist. At the time, I was not menopause certified, but that was one of the reasons why I went that route, was because I thought, I'm a pharmacist and I didn't even pick up on this. But I thought I had dementia. And he said, well, you don't have dementia. That would be rare for you at your age. You may have ADHD. I'm like, okay, that's interesting. That's never been a part of my health journey in the past. So I was sent for some pretty extensive testing for ADHD, which I'm glad for because sometimes people are just diagnosed with ADHD when they don't have it. So I am fortunate that I was able to find a healthcare provider that did very extensive testing. And he told me, you don't have ADHD. And he said, you're probably just anxious. You're a woman, you're in midlife. We just get anxious sometimes and, you're getting older. And I thought, wow, that is really not helpful to me. So I left there really not understanding what I was experiencing. And it wasn't until later when I had other symptoms and started being treated with hormone replacement therapy that I realized that's what this was. This was not obviously not dementia or ADHD. So it can be such a challenge for women as far as, like you said, to feel heard and to know where to go. It's almost like you have to be an expert in your own care to know what questions to ask.
Yeah, so how does that compare? Like an ADHD with brain fog, with overwhelm, with distractibility? Like, how do we? I know you said that we went through testing and you went through testing and stuff like that, but how does that feel to a woman that doesn't quite know what distinctions does that help with? How do
Yeah.
we get to,
I think
yeah,
there's
how
a few
do,
things.
go ahead.
Yeah, I think there's a few things that women can do. I mean, just to kind of back up and talk, so for example, for ADHD is typically a neurodevelopmental disorder that begins appearing in childhood, usually by the age of 12. The testing for it and the DSM-5 criteria really sort of focus a little bit more on hyperactivity than they do attention deficit. So what happens is that a lot of women reach adulthood and may have attention deficit disorder, but it's never been diagnosed. And that's because women and little girls are very good at figuring out how to cope and overcompensate. And so being able to be a perfectionist and very, on top of that calendar and very detail and process oriented can really overcome some of those issues that they think are normal, they just need to overcome. And then once you get into the perimenopause transition, fluctuating estrogen levels are also known to cause cognitive changes in the brain, right? So it can lead to brain fog. It can cause new onset or worsening anxiety, new onset or worsening depression. And it doesn't typically cause new onset ADHD, but it can often unmask undiagnosed ADHD. So I always have one thing that a woman can do is to really think to herself, what is the timing, the pattern, and the history of this? Is this inability to function as well as I have been able to before? And that can mean a lot of different things for each individual woman. But are these new symptoms, are they really just worsening symptoms of a problem that I've kind of had throughout my life? Or are these just brand new out of nowhere? Because if they're brand new out of nowhere, it's less likely that it's misdiagnosed ADHD. But if you think back and you're like, no, really, I've always been able to compensate for this by doing all of these things, and now I'm having trouble keeping up with it, even doing these things. Then you're left with, is this ADHD that was never diagnosed? Or is this just the menopause transition that overlaps with all of the things that we talked about? Or is this a combination of both, which is challenging as far as like how you manage it medically? Could it be a mixture of both now at this point? So women can sort of enter the healthcare system with these symptoms all being the same, but have very different pictures as to how they got there.
Yeah. And how, just to tap on more on that, how does sleep affect all this or lack thereof?
Mm-hmm. Yeah, so sleep is a whole other caveat of perimenopausal, especially in the perimenopausal transition when the hormone levels are fluctuating so widely. And the other, common symptom with the menopause transition being vasomotor symptoms. So sleep is often one of the first or most troublesome symptoms that a woman will present with to her healthcare provider. So, if somebody says, I can't sleep, you really have to dig into that. Even if the woman is having hot flashes and having trouble sleeping, is it you're having a hot flash after you wake up, you're noticing that you're having hot flashes, or are you waking up with a hot flash, right? Because sometimes sleep issues can be hot flash related or not hot flash related. So just the one symptom of insomnia can be so challenging. And then when you couple that with insomnia being a part of many mental health issues, it makes another layer. And then on top of that, insomnia worsens all of those things. Insomnia can really impact anxiety. Memory is a huge impact with insomnia. So insomnia is really a very challenging addition to everything that we've discussed. And with women, oftentimes, I think if you can get your insomnia treated first, then that kind of helps you take a step back and now look at the landscape of, okay, now what are my remaining symptoms? Because like you said, you know that if you're not sleeping, it's going to make all of those worse.
Yeah, I know in my case that was my number one. Well, I guess maybe number two, but the hot flashes I had had at night and the night sweats that I was having kept me up for maybe 6 years, 7 years, and I wasn't having hot flashes during the day. I was having them at night, but that was rough because, as you said, it affected my memory, it affected brain fog, it affected my day and feeling like I was accomplishing something because I just didn't feel like it. I felt like I was taking the motions and going through it and tired and
Yeah.
even talking maybe with my provider at the time, it was kind of like, well, that's menopause, and again, coming back to that feeling unseen or not really feeling. I was tapping on everybody possible, and it wasn't until, like you had said, doing a lot of the testing to see where we were at, where finally, and again, I went to a pharmacist as well to really get deeper into that. But it seemed as each symptom speared its head out, right? Like each one was different, then it took a different step to figure out how I was going to
Yeah.
come back around. So it was very much a kind of a whirlwind around. But also, and therapy, right? I felt like it was time again to really step into therapy. So, what steps can women take or conversations that they can initiate to ensure both mental health and cognitive concerns are taken seriously?
Yeah. I think when you go to your healthcare provider, being very, very specific about your symptoms. So instead of saying I can't focus, if you're thinking more about, I'm having brain fog and I can't focus, being more specific with I am forgetting names or I'm having trouble completing a work task, whatever that specifically is, then make sure you're saying that as opposed to a general description of what you have. Because brain fog, that can mean a lot of different things. So being very specific about that can help sometimes tweeze out a mental health impact a little bit more easily. But I think also just making sure, and this is the hard part because I know I'm saying this and it's not easy, is finding someone who is well versed in all of those things. And even a couple of years ago, or maybe when I was on the podcast the first time, I may have had a bleaker picture around that than I do now. And I feel like we are finally turning the corner on midlife women's health. And I think it's going to continue to improve. For example, with the Menopause Society, they've seen about a 500% in the number of healthcare professionals who have taken the certification exam, are doing the continuing education, and are staying well versed in midlife care. So why is that important? Many people don't realize it, but folks who have the Menopause Society certification, they're not just learning about and understanding how to treat hot flashes. There's also a lot of education about all of the different issues that a woman has. So for example, there's research that shows that women who have severe vasomotor symptoms or hot flashes tend to have worse cardiovascular outcomes. Someone that is certified trained is going to realize that LDL levels, cholesterol levels, will often increase around the transition. So it's not just about helping my brain fog, helping me get rid of these hot flashes. It's all of the other changes that occur around that time that you need to have someone look at, right? So a lot of women will go to their doctor and they'll have an LDL level that's a little above, 100, which is kind of the cutoff. And the physician will say, well, you've never had a high LDL before, so we'll just keep an eye on it. And that's not beneficial at this point. So I think just continuing to look for someone, first of all, who's Menopause Society certified, or just having a conversation with them. And if they're not talking about you holistically, get another opinion or move on. And it sometimes will take kind of like an army of people, right? You might, there are some women that just love their OBGYN and they can get the hormone part taken care of, but they really need their primary care physician to be, talking about and recognizing the cardiovascular changes and that type of thing. So I do believe we've turned a corner. I think more people, and honestly, I think it's because women have been standing up and saying, okay, I am tired of not being heard here, right? There are a lot of us and we are speaking up, and it's really changed things. I think even just with the FDA removing the black box warning for estrogen products, especially the vaginal estrogen, I think we're finally educating people that vaginal estrogen is very, very safe for women to use, and a very important tool in their toolkit for genitourinary syndrome. So I think we are headed that way, but you do really have to be a champion of your own healthcare, and you have to just kind of stay on top of it, unfortunately, yourself. And I think the fact that women are having more and more conversations, I see it in social media. I think that it's easier now to say, hey, who do you see for this? Because it happened to everybody at a different time, and everybody's experience was different. And so you just kind of, like you said, just felt alone in that. So I think we're turning the corner there. Hopefully, if you have me on again in the future, we'll be in an even better place.
Yeah, so you mentioned it just a second ago from when we had you on and even a couple of years ago. What are some of the biggest changes that you've seen that have come about? Like what you just talked about 500% more
Mm-hmm.
people taking a menopause. That's huge. When we discussed prior that only a third of medical schools touch
Mm-hmm.
menopause. So that's a huge shift. I mean, and again, it's still not where we would like it as probably as women or people going through it or to understand it, but what are some of the big changes that you're seeing,
Mm-hmm.
and where do you see some of those changes going, or hopeful the changes that we'll make as well in
Yeah.
the future?
I think in addition to more physicians, and I want to point out the Menopause Society certification is not just for physicians, it's all healthcare providers. So there will be mental health counselors on their website. So you can look up now, and that's one of the nice things is you can look up what type of provider you want to see, if it's a pharmacist, if it's a counselor, if it's a physician, if it's a nurse practitioner, and then you can look and see and find people that way. So I think the number of people that are experts in it is increased. But the biggest changes that I've seen in the past couple of years are one, the research. I think finally now that we are able to set aside some of that data from the Women's Health Initiative that we know was not really didn't really show what we were thinking that it showed. We've got a lot of studies. We've done so many repeat studies since then that have showed the safety of estrogen in a wide variety of women. And so I think we're sort of turning the page on that as well. I don't think we need to continue to do all of these studies just to prove a point. And I'm starting to see a lot of research in menopausal women in other realms of healthcare. And so, for example, we know that sarcopenia, or loss of muscle mass in midlife women, is extremely important. I saw a study just the other day looking at strength training in postmenopausal women and what are the differences between a way a woman in her menopause years is able to build muscle compared to someone prior to that, a woman prior to that. That's huge. We haven't had that type of information before. So we're starting to see studies in menopausal women for things other than hot flashes, which is really, really refreshing. And I think too, the amount of research, another area is the amount of funding for the research for menopause. So Melinda Gates just recently puts millions of dollars into supporting research. You mentioned training earlier for physicians. The Menopause Society and a private donor put 10 million towards physician training in the United States for menopause. So I think all of those things, and I think the next frontier of hormone replacement therapy is, what dose do we need? Like right now, we still dose to the hot flash, right? The symptoms. But we also know that hormone replacement therapy has an indication for prevention of osteoporosis in postmenopausal women. But what level do we need? Levels are very, very difficult to evaluate because they change. How do we know what dose we need to impact bone mineral density, right? Genitourinary symptoms of menopause or urge incontinence. You kind of know based upon your symptoms if that dose is working, but there are other facets of menopause care that we really need to do some dose finding studies on. So I think we're going to continue to have more information for women as we move forward, hopefully.
So, as you were talking about the testing, what are some of the things that are different that when you go in for an annual physical at the doctor and you're doing your labs, as opposed to going to you, that you're looking just a little bit deeper on that maybe women don't understand when they're going into their primary physician and they're going into a specialist like you? What are the differences that the tests are looking for?
There are a variety of tests that sometimes an OBGYN will do that maybe a primary care physician will not. So beyond just an estrogen level, a progesterone level, and like an FSH, it's also important sometimes to look at things like sex hormone binding globulin because that impacts the actual available hormones that you have in your bloodstream to be effective, as well as some physicians will look at prolactin levels. So there are other labs that you can have. The biggest thing is not necessarily the level, or I mean, the diagnosis of menopause is typically done by the final menstrual period being 1 year. But for women who haven't had a period because of a hysterectomy or uterine ablation, then the labs become a little bit more important. There are some more controversial testing done out there with like urine metabolites and saliva. And I think there are some benefits for that. I think it's kind of confusing for women to know when that's important. And sometimes, there's a place and time for everything. But I think having a physician that orders a full panel of testosterone, estrogen, progesterone, sex hormone binding globulin, and FSH, if you're still thinking, is this actual menopause? Those are good places to start.
So, if you were to tell our listeners three things today that they're going to walk away with, what would you tell them?
Oh my. First of all, continue to talk about this with other women, continue to push forward with this, continue to demand answers from physicians and healthcare providers, and know that it is getting better. So that's number one. We are headed in the right direction. Number two is to realize that there's a whole lot more going on than just hot flashes. So this is the time when you really need to think about all of your healthcare, all of your physical health. What is your muscle mass? What is your body fat percentage? All of these things, everything that impacts your cardiovascular system at this point in your life becomes very, very important. Because even if you're taking hormone replacement therapy, you're never going to have estrogen levels and progesterone levels that are as high as they were in your premenopausal days, right? And so it doesn't fix everything. And I think that's the second take-home point, is that women have fought so hard to be put on hormone replacement therapy that now it's kind of like, we're on it, I'm good. But there's a whole other list of things to look into. So I think being comprehensive is the second. And then I think the third is just realizing that mental health really is a big player with all of this that we've talked about, and feeling empowered to reach out. Like you said earlier, this may be the first time in someone's life that they have seen therapists, but that's completely fine. Even if you don't have a mental health diagnosis, just the symptoms of anxiety, irritability, insomnia, all of those can be impacted by a mental health professional. So I always encourage women to not be in the dark and not reach out for help if they need that.
Yeah, if there's one thing that this conversation highlights is that menopause just isn't physical. It's just not a physical transition. It impacts identity, it impacts confidence, cognition, relationships, and all of that at once, or over a span of time. So as we create these conversations around these experiences, hopefully us women can become more support, and men too, and they can become more supportive and as women we can become more supported and empowered and being able to talk. So we thank you very much, Dr. Miller, for being back and this wonderful conversation. And please listen in as we release new episodes of Menopause the Positive Way. And if you enjoy these podcasts, please feel free to share with a friend. And until next time, here's to your continued health.
We are so glad you joined us for this episode of Menopause the Positive Way, and hope you will share this podcast with friends and family. You can subscribe to the series wherever you get your podcasts. Along with this podcast, Positive Health also offers a holistic, one-stop digital health experience supporting your body, mind, and spirit during the menopause journey. If you or anyone you know is looking for guidance, education, and services that address the many symptoms and needs experienced during your menopause journey, you can become a member of our pilot program. And you can join by visiting our positivehealth.com website. That's PAUSITIVE health.com, making life easier and helping you make a change for the better.
This is an educational podcast where the views of our guests do not necessarily reflect the views of Positive Health. The content is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Positive Health does not provide medical advice.